So let's talk about a really common thing that you see in the ED, and that is shock. So shock is going to be really important when we're thinking about trauma surgery, and the reason is because in trauma, you tend to bleed. And two of these things are both caused directly from bleeding. We're going to talk about just sort of your general presentation of shock, and then we'll talk about three of the shocks that tend to come up in trauma. So that's the hypovolemic shock, which is a blood loss, fluid loss, cardiac tamponade, which is a blood loss into the pericardium, and then a tension pneumothorax, which is an injury to the pleura. The three of the causes of shock that we're not going to talk about because they're generally not seen in the trauma setting is the cardiogenic shock, which is usually caused from an infarct or an arrhythmia, which reduces the heart's pumping ability, hence lowering your blood pressure. Septic shock, which is from an infection, which causes vasodilation. That also drops your blood pressure. And then anaphylactic shock, which is due to an allergic reaction, which causes similar vasodilation. All right, so shock in general, to draw a thread through all of these, is a drop in blood pressure. So something below 100/60, roughly. That's where we consider the blood pressure to be abnormally low. And this results in a decreased perfusion to organs, namely the brain, and ultimately that causes death. So there are many, many, many mechanisms that can cause shock. I just named 6 of them. There's another one that's even more uncommon called neurogenic shock. But because there's multiple mechanisms, you can have many different ways of getting shock. There are going to be many different accompanying symptoms, and you're going to need to know those accompanying symptoms to be able to differentiate the cause of shock. So general symptoms, though, with shock are tachycardia, and so the tachycardia is going to be related to the decreased blood pressure. And for the most part, the tachycardia in the early stages of shock are going to be able to help us maintain a normal blood pressure, especially in hypovolemic shock. This then eventually will give out to a weak or absent pulse, and then as you get decreased perfusion to the brain, you'll have altered mental status and ultimately loss of consciousness. So the causes of shock and trauma we're going to talk about are hypovolemic shock, which is usually due to dehydration. In the trauma setting, usually external or internal hemorrhage, and then post-traumatically, usually burns. We try to anticipate that because we know that burn patients lose fluid. And it's not because they've lost fluid externally, it's because they've third-spaced their fluids out of their volume, their intravascular volume. So the symptoms of hypovolemic shock range, and they're going to depend on severity. We'll see what that means. Cardiac tamponade is a hypotension due to an obstruction of the heart's pumping ability. So, you get your blood in the pericardial sac into the space, and that's causing a pressure on the heart, which reduces its ability to pump. And so the heart can't pump, you don't get a cardiac output, you don't get a blood pressure. Tension pneumothorax is due to an obstruction in the lung, the affected lungs, and so this is an injury that happens to the lungs, and you get a reduced ability of the heart to flow out to the lungs, out from the right ventricle, and this is going to result in an increased right heart pressure and a diminished venous supply. So you may see that there are some similarities between cardiac tamponade and tension pneumothorax, and it's going to be really important to be able to differentiate these two apart because clinically they can appear very similar, but there are some key clinical features that will differentiate these two. So let's first talk about hypovolemic shock. So this is a common cause of shock in trauma. When we think about trauma, we think about bleeding. And bleeding happens a lot, and it can be internal or external. So we really need to remember internal, because external can be really obvious. We see the patient bleeding, then we apply pressure there, we can stop the bleeding. But when it's internal bleeding, we usually can't manage that without surgery. So common sites of internal bleeding include intrathoracically, so rupture of the great vessels, retroperitoneally, around the kidneys, intraperitoneally in the abdomen, and the pelvis. And usually when we're thinking about the pelvis, we're thinking about behind the bladder. So this is where our FAST exam is going to be really useful. When we're doing the FAST exam, we're looking at the heart and the lungs. We're looking around the kidneys and the liver. We're looking for any kind of blood in the abdomen, and then around the bladder. So the body can lose up to 15 to 20% of its volume, and that's roughly about 750 milliliters before symptoms even show up at all. And so as we're speaking, you may be volume depleted. That doesn't mean, though, you're in hypovolemic shock, quote unquote, because your body has compensatory mechanisms for that. So what do we usually call it when you're less than 15% of your volume loss? That's usually considered like dehydration. So you don't have any clinical symptoms, but perhaps you may be thirsty. So you can lose a good amount of your volume without having any symptoms. So that's an important fact to know. In trauma patients, the index of suspicion should always be very high since bleeding is common. And again, it's obvious when a patient is externally bleeding, but are they internally bleeding? That's a question. So if they are in shock, we're always concerned about internal bleeding. So what are the symptoms? So remember I said you can lose up to 15% of your volume without showing any symptoms, and that is true, and the reason is because you have a reserve of volume. About 15% of your volume you don't necessarily need. And so you can lose about 15% of your volume without developing symptoms. Now you may have like subjective feelings of thirst or even pallor, but generally this doesn't present clinically. And so this would be considered stage 1 hypovolemia. Stage 2 hypovolemia is usually more than 15% of your volume is lost. So this is around 750 milliliters to 1.5 liters. Remember, your normal volume is around 5 liters. So at this point, we start to have tachycardia. And our blood pressure is still in the normal range. And the reason is because the tachycardia is enough to maintain your blood pressure. You start pumping faster, it's going to increase your blood pressure, and it can keep the blood pressure in the normal range. Remember, blood pressure is the most important feature here. The blood pressure is the most important endpoint, because if you don't have blood pressure, you can't perfuse your vital organs. So another thing you can see in stage 2 and beyond is pale and clammy and cold skin. Why do we have that? When you're in stage 2, at this point, what is usually happening is that your body is shunting blood away from your extremities and from your skin and towards your vital organs, like your heart, your intestines, and especially your brain. And so because you don't have as much blood going out towards your extremities, they're going to be pale, they're going to be cold, because it's where we get our redness and it's where we get our heat from, is our blood. So around stage 2 of hypovolemic shock and beyond, you get the pale, clammy, and cold skin. You also have the delayed capillary refill, since you just, in general, don't have as much blood going there. So remember that your heart rate and respiratory rate can be are elevated in stage 2, but your blood pressure tends to be normal. Now, when we're thinking shock, the typical shock, we're thinking low blood pressure, and this is what happens at stage 3. So at stage 3 of hypovolemic shock, your body's compensatory mechanisms, namely increased heart rate, is not enough to maintain a normal blood pressure. And so at stage 3 of shock, your systolic blood pressure drops below 100 millimeters of mercury. Usually at this point, you start to have some significant mental status changes, anxiety, confusion, or even agitation. And then stage 4 is the end stage of hypovolemic shock. Your systolic blood pressure has dropped below 70 millimeters of mercury now. Usually your mental status is lethargic or even comatose. So what do we do for hypovolemic shock? Well, of course, we need to replace fluid. It's important to do two things: replace fluid and to stop the bleeding if at all possible. Now, if it's external bleeding, we can stop the bleeding with direct pressure. If it's internal bleeding, well, then we're going to have to get the patient off to surgery as soon as we can. But the first thing we need to do is get fluid into the patient. So large bore IV lines, we'll want to insert these bilaterally if we know that the patient is volume depleted. Usually you'll place these anticubitally. 16 to 20 French. You want very, very, very large IV lines. And the reason is because if you remember Poiseuille's law, your rate of flow is proportional to the fourth your diameter to the fourth power. So the larger your IV lines are, the faster you're going to be able to get fluid into the patient. So you'll want to provide the patient with normal saline. At the same time, while you're putting fluid into the patient, you'll want to get blood studies, so coagulation studies and the patient's blood type. But a lot of times these don't come back fast enough. And so a good way to get around that is to have O-negative blood on hand, because O-negative blood is, nobody will react to O-negative blood because it doesn't have any antigens on it. Another thing you'll want to do is to insert a Foley catheter to monitor their urine output. A urine output is a good urine output is reassuring that the patient has got an adequate volume. And then, like I said, maintaining adequate blood pressure is critical. So if you have a blood pressure better than 100/70, then you're reassured that the patient is not going to die from hypovolemic shock. So maintaining an adequate blood pressure is absolutely critical. And then, of course, also important, as well as treatment, is to correct the underlying cause. Because if you have internal bleeding and you're not correcting that, then you're just going to keep bleeding, and all the resuscitative measures in the world are ultimately not going to be enough. So you'll want to find and correct the underlying cause. Remember that FAST exam is very helpful for finding internal bleeding, but it may be external bleeding, and you can correct that as well with direct pressure. So this is a general, generally how the symptoms progress in hypovolemic shock, but you should just have a general idea that when you have blood loss and you have shock, it's hypovolemic shock. This staging is called the tennis staging, and the reason for that is because this is the same way you score in tennis. So instead of 1 point, 2 points, 3 points, and 4 points in tennis, you get 15, 30, 40, and then you win. So that's why it's called the tennis staging. That might help you remember where stage 1, 2, 3, and 4 is. So, all right, so that's hypovolemic shock. Cardiac tamponade. So this is an accumulation of blood in the pericardial space, and because of the pressure that places on the outside of the heart, that's going to reduce the heart's pumping ability, and that diminishes your cardiac output and hence your blood pressure. There's acute and chronic forms of cardiac tamponade depending on how slowly or how quickly you're losing blood. If you lose it very quickly, it's going to be more of an acute problem. If you're losing it very slowly, it can be more of a chronic problem. So patients who have a very, very, very small blood loss or fluid loss into their pericardial space, they have the chronic tamponade, and that's not really seen acutely in trauma. What we do see in trauma, usually due to either blunt or penetrating trauma, is the acute tamponade, where it doesn't take much blood to cause the tamponade. With chronic, because your heart can adapt to it, you can actually get quite a bit of fluid around the heart before you start to really have problems. Just remember, with trauma, it doesn't take a whole lot of blood in the pericardial space to cause cardiac tamponade. The key symptom with cardiac tamponade, and this is what's going to help you differentiate it at least from hypovolemic shock, is distended jugular veins. Now, with hypovolemic shock, you have a loss of volume, so you're not going to have distended jugular veins because you don't have enough volume. With cardiac tamponade, you're blocking up the right side of your heart because you can't pump blood out. And so everything's going to get congested. Just like in congestive heart failure, you'll have those distended jugular veins. You're going to have them in cardiac tamponade too. And so this is due to right heart congestion. But what you will note also is that the patient can breathe fine and they have normal breath sounds on auscultation. And this is going to be important to differentiate it, as you can imagine, from the tension pneumothorax. Another thing that you can hear on your physical exam with cardiac tamponade is muffled or distant heart sounds, and that's because you've got blood surrounding your heart, and so that sound is being transmitted through the blood, and that muffles it a little bit. Some other symptoms that you may see are pulsus paradoxus. I've really never gone so far as to try to look for this in a patient, but pulsus paradoxus is a greater than 10 millimeter of mercury drop on inspiration. So normally you should your blood pressure should drop on expiration. In this case, it drops on inspiration. And then an EKG, if you have one attached, you may notice a decreased QRS amplitude. Remember, your QRS is your pumping, your left ventricle pumping, and so that would make sense that you would have a decreased QRS amplitude. The diagnosis is via sonography, so if you see a patient, a trauma patient with distended jugular veins, especially if they are in shock, then immediately you should be ultrasounding their heart. And you'll see the blood collecting around their heart. It's a black line, and that's going to help you diagnose the cardiac tamponade. And we treat this surgically via pericardiocentesis. We just extract the blood out of the pericardial space. And that takes the pressure off. Okay, so here is a hemopericardium. And you can't, just by looking at this ultrasound, you don't necessarily know if this patient's in tamponade. But what you do have here is something around the heart that's possibly fluid, possibly blood, but in the setting of a trauma patient, this is probably blood. So this is what you would see in a tamponade patient. So normally you don't have this black space here, this hypoechoic space. It should just be, you may see a little bit of it, black space, but not this much. Okay, and then here's another one here. So you see hypoechoic space right here. And this is your left ventricle, right atrium here. Okay. So diagnose for tamponade on ultrasound. Tension pneumothorax is a disruption of tissue which causes a progressive accumulation of air in the pleural space, and that results in increased pressure in the pleural space, which ultimately is going to press onto the heart. So it's kind of a similar mechanism to what we get with the tamponade, in that we're getting pressure onto the heart. We're getting pressure being placed onto the heart, and this is going to reduce our cardiac output. So again, we have pressure on the heart, but in this case, it's not due to blood in the pericardial sac, but it's due to air in the pleural space, and you get an increased air pressure. Every time you breathe, you get more air into the pleural space. So this works by this one-way valve mechanism, and every time you breathe, you get air going into your pleural space, but when you breathe out, it doesn't come out of the pleural space. So the pressure just gradually increases to the point where your heart can't pump out anymore. So what are we going to see here? Well, again, because we have a heart that can't pump properly, you're going to get distended jugular veins, just like congestive heart failure. But what you will also see here, what you don't see in cardiac tamponade, are absent breath sounds on one affected side, or what you may also see, and which is probably going to be more evident, is the patient is going to have dyspnea. They're not going to be able to breathe. They're going to have shortness of breath. And so with the cardiac tamponade, you'll have distended jugular veins, but the patient can breathe fine. With tension pneumothorax, you'll have distended jugular veins, but you'll have all these pulmonary symptoms as well, such as dyspnea, and then absent breath sounds on one side. That's going to be the affected side. And if you do percussion, because you have all that air in the thorax on one side, it'll be hyperresonant to percussion. So if you've already gotten a chest x-ray, which you don't necessarily need to do, especially because this can be emergent, if you do get a chest x-ray, though, the affected side will demonstrate the collapse of the lung as well as the air and the space. I'll show you what that looks like on chest x-ray. Technically, this would be your best way to diagnose tension pneumothorax, but you can diagnose this clinically, especially if the patient is in severe shock. So the treatment here is needle decompression. A lot of times this will be done out in the field by the EMT, and the needle will be left in, because if you take the needle out, you're back to square one again. So you decompress the tension pneumothorax. The needle will be left in then until you can place a chest tube, and that's done surgically. And that'll be secured until you can get some definitive treatment. So here's a tension pneumothorax, decreased pulmonary markings on the left side here. Here's another one. As you can see here, the left hemidiaphragm is placed way down, and that's just due to the increased pulmonary pressure. Well, not pulmonary pressure, the increased pleural space pressure. So this pressure is also pushing on the left ventricle here, and that's what's also going to cause your decreased cardiac output. So it's an increased pressure restricting the heart. So these other causes of shock, which I kind of talked about earlier, these are not usually trauma-related. The cardiogenic shock, this is usually due to an infarction of heart muscle or an arrhythmia, and that reduces the heart's ability to pump. Septic shock is due to an infection, and this results in vasodilation because of the inflammatory mediators, lipopolysaccharide namely. And in these patients, usually there will be a fever, and the skin will be cold and clammy. With anaphylactic shock, it's similar to septic shock as far as that you've got inflammatory mediators and vasodilation, but in these patients, the fever will be absent and the skin will be red and sweaty, and that red and sweaty skin stands in contrast to all the other causes of shock. And again, in these, just remember to put it in clinical context. These patients will usually have a history of bee sting, or they've ate something, or they're on some kind of medication, etc. And then neurogenic shock, somewhat uncommon. This is due to spinal injury, and the spinal injury causes a loss of autonomic reflexes, which reduces the body's ability to increase blood pressure as necessary. So here's a shock algorithm you can use for trauma. So remember your typical symptoms of shock: reduced blood pressure, increased heart and respiratory rate, altered mental status, oliguria. First thing to ask yourself, do you have distended jugular veins? It's the first thing to ask yourself, because if the answer is no, the answer is hypovolemic shock in most cases. And so with hypovolemic shock, we'll start IV lines. If we haven't already, we'll start to push fluids, get in a Foley catheter to make sure that the patient is producing urine, and then you want to search for and correct the underlying cause. If the patient does have distended jugular veins, then you know that the problem is due to the heart's pumping ability. In this case, then, we want to know, does the patient have a shortness of breath? If the answer to that is yes, then it's probably a tension pneumothorax. And the treatment for this is needle decompression followed by chest tube placement. If they don't have shortness of breath, then we will presume cardiac tamponade. Of course, we're going to want to make sure that we get an ultrasound of the heart before or while we're placing the needle in to take the fluid, the blood, out. All right, so this is sort of your decision-making guidelines roughly for the test. If you have any questions, write a response. See you next time.